Well, now we're going to switch gears just a little bit and talk more specifically about differential diagnosis. We have to ask ourselves this question first, how can we recognize childhood apraxia of speech, given that these children come to us with many co-occurring inefficiencies, if you will, in neural processing? So we have to, first of all, consider a number of things such as the medical history, the developmental history, issues related to their speech and language development, issues related to how much therapy they've had and when and what kind of progress did they make. The most important thing we do, however, when we're trying to come to a differential diagnosis, when we're trying to decide if we recognize any characteristics that we associate with childhood apraxia of speech, is that we make observations. This is what we do in all assessment, isn't it? We make observations. We make behavioral observations that are both speech and non-speech. Speech characteristics probably being the most important. And then we compare those characteristics with those commonly accepted characteristics related to any particular label. So for example, children that have phonologic impairment, the characteristics we typically associate with that are predictable, developmental, and consistent sound substitutions, or processes that can be identified, such as fronting, final consonant deletion, cluster reduction, typically produced in a fairly consistent fashion until they've been in therapy a while and begin to generalize. We make these observations across contexts. We're making observations while we talk to the child. We make observations during testing. So we have typical language, speech, cognitive assessments that are in our toolbox as SLPs. I'm going to be talking a lot about the importance of a motor speech exam when we're looking for the possibility of a motor speech disorder, and I'll be making the argument for dynamic assessment. Now, testing isn't always standardized, and it certainly isn't always normed. For example, a standardized test is one that is specified as to what you do and how you score, and you do it the same way each time. It may or may not be normed. A normative test is one that's been given to many children across a broad spectrum, and then the scores of any particular child are compared to that larger sample. Well, sometimes, lots of times, we want to know where a child performs in relation to a big sample of children their age. Other times, we're more concerned about comparing or looking at that child's ability to do very particular processing related to that level of processing. It'd be like taking a test. This is called Criterion-referenced. If you're in school and you study and you're going to take your, let's say your undergrad speech and hearing anatomy course, and it's time for the final, that test is Criterion-referenced. That is, you're not looking at your score relative to everybody that's ever taken that class. You're looking at that score relative to how much of that information you knew. So some of the testing that we do is Criterion-referenced. Some of it may be normative. Some of it may be standardized, and some of it is not. Some of it is just the observations we make in our interaction with the kids. Here's an example of a speech protocol for children that will help you determine whether or not that child has characteristics of apraxia of speech. So first, we do a language sample. We do this with most of the kids we see, don't we? Especially the younger kids or kids that have more severe speech impairment. So we do this language sample in free play, where we make observations based on whatever the child happens to bring up or say or produce. But we might want to get more information, so we might also choose to do some structured play. So I have this box with very particular toys in it that represent certain movement gestures that I want to see how they try to say. So I might have a dad or a dada, whatever the child says, or whatever I model, and see if I can get them to say, a mom, a baby, a puppy, other items that might be easy, especially if we're talking about kids that are not quite verbal or low verbal. but varied in their vowel content and syllable shape. So that would still be in a play format, but here I have items that I've picked particularly to try and elicit in a play format. This allows me then to make observations regarding phonemic and phonetic inventories and look and see whether or not I also notice any apraxia of speech characteristics. Next, we can, if the child's able, do a test of articulation or phonology. And of course, that helps us examine where the child is in terms of their phonologic skill development. We almost always do a structural functional examination, at least in our clinical thinking. Most of the time, many times, we don't have to sit with a tongue depressor and a stopwatch and actually have them do all these things that we learn to look for in a structural functional exam, often called oral peripheral exams, because we can see that the child has normal range of motion, strength, and speed just in the way that they're talking, just in the way that you've seen them chew and eat. We know that all the structures are fine. But maybe we aren't sure about that, in which case we'll do a more formal structural functional exam, and that helps us determine or rule out the probability of a dysarthria. Now, it's at this point in the assessment, because this is the only thing we do that's in a non-speech context, is when I'll test nonverbal oral apraxia as well. And usually I'll just have the child, I'll have a few items next to me, usually some kind of a doll, or if mom's there, I might just say, give your mom a kiss on her cheek, and see how they do that. I might have something they can blow on. I'll have them imitate me, go, or even if they're having a lot of trouble, just say, see if they can imitate versus, so that you get a sense of how well can they specify movement for a nonverbal but oral volitional movement. And next is the motor speech exam, and I'll be talking about this at some length. You know, we've used motor speech exams for years in adults, but rarely has it been talked about for use in children. And I want to argue strongly that, well, at least in my clinical practice, in my hands, the motor speech exam is the most important tool that I have had to help me distinguish whether or not and to what degree a child might have characteristics of apraxia of speech. So this purpose for the motor speech exam is to make further judgments regarding the presence and also the severity of CAS characteristics.